I'm Dr. Ted Rosen, Editor-in-Chief of the Dermatology Digest. And I'm here at Maui Derm, and we talked about infectious diseases. Let's start with the two big sort of scourges in recent years. COVID. COVID isn't over. Luckily, as it's mutated, it's become less and less virulent. But still, 100 to 200 people a day in the United States, which is the number one in terms of deaths and cases, 100 to 200 patients a day die every day from COVID, still. So it's still with us. We're running out of useful drugs, which is a bit of a problem. And as the virus mutates, our various vaccines start losing efficacy. So we have to keep after it, kind of like we've done for influenza for many, many, many years. But COVID's still around. How often does that affect the skin? Used to be when this whole thing started, it was very common. Now, about 3 to 4% of COVID patients, acute disease, will have skin manifestations, mostly non-specific. And even long COVID or post-acute syndrome, about 8% have skin manifestations, again, very non-specific. So not a common thing that you see with COVID. How about monkeypox, now properly called mPox? Well, that was quite the problem, and then it kind of disappeared. Both the World Health Organization and our own CDC said, no longer a public health issue. They were a little premature. The original type of mPox still circulates in the US, about 6 to 10 cases, new cases a day. That's very low across the entire United States. But there's a new form of mPox. We had clade 1 and clade 2. You could think of clade as a strain. Now there's clade or strain 1B. Much more contagious, much more virulent than the original mPox, and it's running through Africa. Now, used to be there were about 6 countries in Africa that had mPox. There are now 15, and this new strain has now been detected in multiple countries in Europe and now in the United States. There is a drug to treat mPox. It's called tecovirimat. However, as is true of all infections, the organism has learned to live with it, and there are resistant strains. So we're still going to have to deal with that virus. How about some other viruses? Guess what? Measles is back again. We had a lot of kids who didn't get their vaccines during COVID, so we have a large susceptible population. It's back. And how about a new virus? It's called the Oropouche virus, and it causes Oropouche fever. It's seen in very few countries in the Caribbean and in South America, but it's particularly rampant in Cuba. Now, I know it's a little difficult for Americans to travel to Cuba, but there are a number of criteria that allow us to go there. If someone comes back to Cuba with a non-specific eruption and fever, myalgia, arthralgia, the usual stuff, headache, think Oropouche. There is a serologic test that you can order. There's no treatment, it's all supportive therapy, but it's a new virus that's threatening us. And an old virus has resurfaced, Marburg virus, with about a 67% mortality rate. It's been kind of quiet for a long time. There was a sudden surge of that in Burundi. That's gone away, but now it's roaring through Tanzania. So old viruses often raise their ugly little heads even when they think they're not a problem, and we have new viruses to deal with. How about bacteria? The one thing that's most worrisome to me is tuberculosis. There was a very recent study that looked at extremely drug-resistant tuberculosis organisms. OMG, hundreds of strains resistant to rifampin, INH, fluoroquinolone, and some or all of the new anti-tuberculosis drugs. This poses a real problem. Remember, it wasn't that long ago that patients died of tuberculosis. They went to sanitariums so they would be segregated from the rest of the population. And the thing that's a little concerning is that statistics suggest approximately 1 in 50 of the people who've been coming across our southern border carry either active or latent tuberculosis. They are told to get tested when they cross the border. They don't, and there's no way of recalling them to check that they have or haven't done that. So it's a bit of a problem. And remember, about 20% of tuberculosis patients may have some cutaneous sign. Usually it's pretty subtle, but sometimes it's quite striking. So the majority of tuberculosis cases in the United States are seen in patients who were not born in this country. So if you have someone who's recently arrived, especially from places like India, Brazil, China, and elsewhere, you at least should test them for TB. And of course, we have blood tests now for that, the Gold. What else? Fungi are really going wild. First of all, the endemic fungi are no longer limited to the areas where they once were. For example, coccidioidomycosis is not limited to the San Joaquin Valley. Histoplasmosis is not limited to the Mississippi River Valley and tributaries. These things are now very widespread. So we have to worry about the endemic fungi. And how about our fungi, the dermatophytes? They're getting resistant. We have Trichophyton mentagrophytes type 7, has a particular propensity to be spread by close, intimate, personal contact, if you get my drift, often resistant to terbinafine. And we have Trichophyton indotineae, started in India, but now it's seen all over the world, which is Trichophyton mentagrophytes type 8, just to confuse you a little bit. It's almost always resistant, 70 to 85% resistant to terbinafine. Oh, and as a bonus, about 40% of the time it's resistant to itraconazole, and you have to really resort to second and third line drugs to try and treat it. So fungi have become a major problem, but only 2% of all infectious disease research funds are spent on fungi. We have no vaccines for fungi. It's been ignored, and it's now killing people. All those saprophytic fungi, like Fusarium, Scopulariopsis, and others, which can cause simple things like onychomycosis, can get in the bloodstream of immunocompromised or immunosuppressed patients. So fungi deserve more attention. And if you have someone who's reliable for a dermatophytic infection, and they've taken their terbinafine, and they didn't get better, you need to get a culture, you need to identify the organism, and try and get antifungal susceptibilities. Watch for my paper on that subject that's coming up that'll tell you exactly where to do that and how. So what else do we have going on in the world of infectious diseases? Parasites don't want to be left out. So now we have head lice, widely resistant throughout the United States to the usual permethrin and pyrethroids. But we do have a new drug, relatively new drug. It's been around for a decade. Most people don't know about it or forgot about it. It's called spinosad, 0.9% suspension. And that's a good alternative when other things fail. Also, don't forget physical modalities to treat head lice. Extensive combing and heat. Heat dries those guys out and they desiccate and die. Not to be left out of the fray, Sarcoptes scabiei, the cause of scabies, has about globally a 15% resistance rate. That's to permethrin and to oral ivermectin. So we're having trouble with scabies treatment as well. Spinosad, the same thing I just talked about for head lice, was recently approved for the treatment of scabies. It's a single, as you would use any other topical, single from the collarbones on down application overnight. And it has about an 80 to 85% cure rate. You can redo it if need be, but it's good to have another approved agent since the other ones are now failing. We are on the brink, I fear, of an infectious disease apocalypse. The organisms of all kinds, bacteria, viruses, fungi, parasites, are learning to live with the things that we throw at them. So my concluding remark is, please be very careful when dealing with presumed or known infections. Use the right drugs for the right duration and at the right dosage. Always try and make sure of your diagnosis so that we don't use anti-infectious agents promoting resistance for something that isn't even infectious. Thank you for listening.